Point of View is brought to you in association with Stanbic Bank, moving forward.
Hello, this is The Point of View. It's on CTTV, and we are here to bring you the best current affairs discussion on TV with the right guests asking them relevant questions on the issues that matter to you. It's live and interactive with your comments welcome on our WhatsApp number on the screen, and of course with the Facebook stream you'll be watching. If you're on Facebook, there's a lot of discussion on our topic. Tonight we have a very exciting question. So Ghana is one of 3 African countries to have piloted the usage of the now tried malaria vaccine for children. It's generated a bit of discussion globally. We'll be looking at the pros and cons of Ghana being part of this process, why only 3 African countries are part of the initial usage, how far back have we been in working with the people putting the vaccine together, and how will it reduce the incidence of malaria in our country. These are just a few questions. I'm sure you have a lot more. My guests, I'll tell you who they are when I come back, and you can put your questions to them as well. Stay with us. So welcome back to The Point of View. So tonight is a health discussion on the new malaria vaccine, and we're asking how safe is it? Is there any issue of concern? If you've been following social media in Ghana for the past few days, you would have noticed certain videos circulating of people warning Ghanaians not to take part or allow their children to take part in the trials for many, many reasons. We'll try and see if those points on social media are valid, and we'll try and see if we can get the right situation. My guest, Dr. Kezia Malm, she is the programs manager for the Malaria Control Program. Doc, great to have you. Welcome to the show.
Thank you for having me.
I also have a gentleman in charge of an NGO that's not very happy that Ghana has agreed to be part of the trials. Evan Stewart is for the Coalition for Ghana's Independence Now. Sounds like Kwame Nkrumah all over again. So that's the name of your NGO, Ghana's Independence Now.
Yes.
So you're not independent yet.
It looks like our independence has been sold back, and it's the right time for us to get it back.
Get it back. Brilliant. So let me start, as I always do, by giving you a flavor of the stories that have come up on this. So if you go on our website, there's quite a number of stories in the past 2 or 3 weeks on this issue. So, for example, the Ghana Health Service was to pilot the vaccine trials the vaccine usage in April. And then the Health Ministry also announced that it will launch the vaccine in April. And then it started with a test in Malawi. Don't forget, there were 3 main countries, Ghana, Kenya, and Malawi. And then anti-malaria vaccine propagandists were rented, according to the Deputy Minister for Health, on the big issue this Saturday. He wasn't very happy with the comments coming around on social media in particular. Also, Ghana Health Service this morning admitted on radio that education could have been better. That was in my interview with Dr. Nsia Sari. He thought that there was the potential for speculation. And indeed, in the US, there's a whole movement against vaccines. And indeed, there are some parents who don't want their children, even in that country, to use any vaccine at all. We also know that in northern Nigeria, for a long time, the people there have refused usage or administration of a certain vaccine against polio. And we've seen the consequences as well. So tonight, we're asking, who is developing this particular vaccine? Is it the only strain? Now, how far back have we been working on this vaccine? When were the trials done? How successful were these trials? Why did Ghana choose to be part of the initial rollout together with Kenya and also Malawi? Some people think if you go to India, if you go to Indonesia and other parts of Asia, they have a lot more people with malaria. Why are only African countries going through the initial test? These and many more questions. So, Doc, let's start with you. Give us some context. Thank you for joining us. So, even though it was announced that the vaccine will be rolled out in April 2019, I'm sure there's a long history to this. So, give us a quick history of this particular vaccine and when we started working on it.
Okay, so good evening to your viewers, and thank you for having me here. Yes, the vaccine, we launched it on 30th April, and started the implementation on 1st May.
Okay.
But it has been a long process. It's been in development for about 30 years.
Okay.
Usually when vaccines start, it takes a while, and it's been difficult for the malaria field because of the diversity of the parasites. But eventually we got a vaccine. There are a number of vaccines being tried, but this is the most advanced. This has been the most successful. So it was first tried phase 1 after the animal studies. It was tried in 20 US citizens, and that's phase 1 to check the safety of the vaccine. So that went through. Then it moved to phase 2, which was done in Mozambique, where around 2,000 children were tried. And the phase 2 trials is looking at efficacy and even more results on safety.
Okay.
Then it moved to the phase 3 trials, where it was tried in 11 sites in 7 African countries. Ghana was one. In Ghana, we tried it in Agogo and in Kintampo. So in Ghana, for instance, it was tried in about 3,000 children, and the results were quite good. It was found to be safe. And all these steps gave us data on safety, and it was found to be safe. It was found to reduce malaria 4 out of 10 in children. It reduced severe malaria, which can lead to death, 3 out of 10.
Okay.
It was also able to reduce anemia due to severe malaria, 6 out of 10.
Okay.
And if you look at the number of cases that we confirmed in Ghana last year, 5.5 million cases confirmed. If we are able to reduce 4 out of 10 in these cases, it's for the children under 5, it is a huge gain. So as a country, one of the reasons why we did apply was we had tried it and we had seen the results from the trials. And we thought that looking at the burden of malaria that we had and looking at the history of how vaccines have been able to help, bringing in the vaccine as an additional tool to the existing interventions was going to do the country some good. So we applied together with a number of countries, and thankfully Ghana was selected. Some of the criteria that WHO used to select us was because we had a strong malaria control program, we had a robust immunization program, and we did have malaria parasite levels in children under 5 above 20%. So that's made us eligible to be called to pilot this.
Some people are asking a lot of questions, and before I even come to my other guest, so we are told that the countries that account most for malaria incidents are mostly in Southeast Asia in terms of numbers, raw numbers, not percentage of population. And they say, for example, India has the highest malaria burden with 24 million cases per year, followed by Indonesia and Burma. This is World Health Organization facts.
You see, when
I haven't even asked the question. So their question is that how come the countries which have the... So, for example, they said there are 103 million cases of malaria globally. And if you look at that, South Asia has the highest number, raw number, not percentage of population. And they're saying India, Myanmar, and Indonesia. Yet, why aren't any of those countries taking part? Why isn't it being trialed or tested in those countries?
I'm not sure what exactly they are talking about. But what I can say is that 10 countries plus 1, which is India, accounts for over 70% of the world's malaria cases. So I'm not sure about BEM. If you mention India, then I know that it's part of the 11 countries that account for the highest burden. Malaria, the epicenter of malaria is Africa.
When you say burden, are you talking about percentage of a population that has it, or just the raw number of people who are affected by it?
In terms of numbers, in terms of proportions. And you see, when you come to disease prevalence, what you need to do is to standardize the comparison by the population that you are looking at.
Okay.
So India generally has a big population, a very large one. So you can't take it's very wrong to take the absolute numbers, because you may see a few more numbers here as compared to that, but the underlying population makes the difference. And it becomes more of a problem to a particular country than that of another country because the underlying population is quite huge. And last year, WHO reports stated it categorically that 10 countries in Africa plus 1 in India account for over 70% of the world's malaria cases and deaths. 90% of the world's malaria is in Africa.
Okay.
Africa is the epicenter of malaria. We have the greatest problem when it comes to malaria. I'm sure there would have been a lot of backlash if this was tried somewhere else where that is not where the problem is. And people would have asked, why are you doing it there when we have the problem? Why don't you help us solve the problem? So I'm very happy that it was tried in Africa where we have the problem the most, and we are piloting it in Africa where we have the problem the most.
Okay. Just to give me some quick background again. So you say this was initially tried in the US.
Yes.
And then Mozambique, and then 7 other African countries. Do you have the years? I just wanted a sort of flow. Because you said it's been in development for 30 years.
Yes.
30 years.
Yes.
So when you say US, it was a trial? Phase 1?
Yes, phase 1 trial.
In the US?
Yes, I don't remember the exact date for the US phase 1 trial, but I know the phase 2 trial was in 2004 in Mozambique.
Okay.
And then we started the phase 3 trial somewhere around 2006, 2007, all the way to 2013 in the 7 African countries: Ghana, Malawi, Kenya, Mozambique, Burkina Faso, Gabon. Yes, I hope I haven't left anyone out. But there were 11 sites in these countries.
I see. And when the opportunity came for the rollout, Ghana applied.
It was an open call where countries were asked to apply to pilot the vaccine introduction. And just to throw a little light, generally, when it comes to vaccines, after trials, there's something where we call phase introduction or pilot introduction, because trials are done under strict clinical trial conditions. So we do what we call the phase introduction or pilot introduction to see how, to see how the routine service can adapt to it, issues that can come up from the routine service. And for most of the other vaccines that we use, by the time they get to our country, they've been introduced in the other parts of the world because these diseases do exist today. But malaria exists mainly in Africa. That's how come it's something new to us, but it's not really new when it comes to the way vaccines are introduced.
All right. So thank you for the background. I appreciate it. I'm trying to get a timeline of what you described that I'll put up to explain to people how far we've come with this. But Mr. Evans, Teria, thank you for joining us. You issued a statement a couple of days ago.
Yeah.
And the statement was essentially asking Ghanaians not to avail themselves to use the malaria, or for their wards to be for the vaccinated. Why are you against this?
Thank you, and good evening to viewers across the world. This campaign, from our point of view, did not start in 2019.
Okay.
We started this campaign in 2015 when government wanted to try the Ebola vaccine in Ghana.
Yes.
And we raised 2 concerns. One, and my mom, Doc, alluded to one of our concerns, that there wasn't any Ebola patient in Ghana. Therefore, if you want to test Ebola vaccine, it will be difficult to see how potent or the efficacy of the vaccine. That is 1. 2, when we checked our only Public Health Act, which is Public Health Act 2012, we saw that Ghana government is so irresponsible, and it's painful that the laws of the land says that you can avail yourself for any form of vaccination or immunization, but when you get injured, the state, the authority, the vaccine company is immune and indemnified from prosecution.
So you are saying which law? You are quoting
the
Public Health Act 2012.
2012. So let me give you the section.
Yes.
Section 159 and section 172. Okay.
And what do they say?
I can read here. I can read it here.
Yes, I'm just trying to. So you're saying that the Public Health Act 2012, sections 159 and 172.
Yeah.
If you can paraphrase, don't even need to read.
Okay, so in one of the sections, it says that before the authorities go out to immunize or do vaccinations, they should let the people sign a form which will indemnify the authority which is carrying out the exercise should there be an adverse effect of the vaccination right there when it is going on, or some days after, or some long time when a person realized that he or she got this adverse effect through the vaccination, the authority is immune and indemnified from prosecution. And with our research, we realize that in other countries, when the state is not taking the fund that used to compensate people when they get vaccine injuries, the state in its own wisdom makes sure that the companies and all the pharmaceutical companies and importers of drugs into the company contribute into a fund that is used to compensate people who get injury out of vaccination. Because if vaccines are so safe, 100% holy, it doesn't harm anyone. You understand?
So your point is that
vaccines,
our government has not, it makes people sign something to indemnify the company administering.
And the country itself.
That's number one.
You understand?
And that in other countries, they contribute
in other
into
countries,
a fund.
So in short, in other countries, there are vaccine injury compensation programs running.
Vaccine injury compensation programs.
You understand? So I just gave you an example. So I'm thinking, I'm putting my shoes in the shoes of Ghana. That maybe Ghana is saying that, we don't have money to compensate our vaccine injury victims. So Norway is an example of that country. When we are done, I'll give you a document. Norway is one of that company. Norway has set up, the government has set up the vaccine injury board. But the fund is contributed by the pharmaceutical companies. And I think this makes sense. You understand?
Is this fund administered during trial or rollout? Because we need to distinguish between a trial and a rollout.
The fund is only touched when somebody has got injured through vaccination. And as I'm sitting here, I'm a vaccine injury victim. But that was in the 80s, polio vaccination.
Wow.
Even in 2012, when we had this law, they couldn't factor that. So think about the 80s.
So a law couldn't take retrospective effect.
You understand? So what we are saying is that right now, we are not saying nobody should go for the vaccination, but until the state become responsible, nobody should go. Because
so you're saying the first issue is that there is no program for people injured during the vaccination. If there's an injury.
Yes, and this is something we want our health people to admit. They shouldn't paint the picture that vaccine can injure anybody. When that happens, when somebody even get injured, instead of tracing it to the vaccine and go to the nearest hospital, they will trace it to a before and all sort of spiritualities. And a lot of people get injured or adverse effects.
Do we have facts on people who have, what's the incidence of injury in previously administered vaccines? Because in fact, I've done a bit of work, clinical trials in Ghana, evolution and current landscape. I'll share some of the things here.
Exactly.
So we started doing these things in the 70s, and there are some very interesting findings. But Doc, quick reaction to that. I know you have other points to make. So he's saying that there's no vaccine injury compensation program in Ghana. Is this correct?
Bernard, I'd like to educate. So let me before I answer your question, let me just make a point here that if you look at the benefits of vaccines, telling people not to go for the vaccines because there is no vaccine injury compensation in the country is a disservice to the people of Ghana.
That's not true.
Why?
Measles, let me just take one example. Did you know that in the 1970s, measles was second to malaria in terms of causing death and morbidity in children in the country? I haven't seen measles in a very long time. How did we come here? Vaccines. When was the last time we saw a child with polio? We don't see polio anymore because of vaccines. And just to correct, I don't know how, I do sympathize with Mr. Terry. I think I've met him on another program and I said, I do sympathize with you. I mean, in terms of the challenge that he has. But just a few corrections. Polio vaccine is oral. It's not by an injection. Sometimes, that's why we keep telling
But
people.
how does that change the fact that he said he was injured?
Yes,
or he suffered an adverse effect?
Maybe he would have to explain.
So are you saying that because it's oral means nobody can suffer an adverse effect?
No, adverse effects do happen. And we have a system of monitoring the adverse effects. And what we encourage people is that if you happen to have any adverse effects, please go back to the health facility that you had the vaccine. We have a system in place where we assist people, where we take care of the adverse events that happen. And we report. We have an expert committee under the Food and Drug Authority that looks at all these adverse effects and examines them, investigates, and then we do what we call causality to show whether whatever has happened is linked to the vaccine, is linked to, and this is not limited to vaccines, just to let you know. It's to all medicines in the country, vaccines inclusive. And if the FDA happens to see that a particular drug, a particular vaccine is causing an adverse effect, I can assure you they will withdraw that
There's
medicine.
a view that the potential adverse effects of vaccines are more than those of drugs. Yet the rules regulating drug trials are more stringent than the rules of regulating vaccine trials.
Unfortunately, that is not very true. If you look at, in fact, this same public health, I'm yet to see the part that talks about the indemnity when it comes to people who administer drugs and things. Because I can assure you, if you go to any health facility and you are given anything, let's not limit it to vaccines, and you are given anything that there's evidence that the health worker is negligent, something, you take it to court. It's happening. There is nothing like, because they're giving, and nobody signs a consent form in the routine services. Consent forms are signed in clinical trials and tests. And that is an ethical standard everywhere. And in the consent form, you explain very well to the person what the trial or test is about, the benefits, the risk, and the person can refuse to take the whatever vaccine or drug you are given to. And that's for the trial purpose. But this particular vaccine has gone way beyond that. We are using it in the routine
But
health
do you
service.
admit to the question he put out that we do not
We
have...
don't have a vaccine injury compensation.
But there are other countries that have it. Are you saying, as a public health official, that you don't know that other countries have this? Some countries have this.
I can't cite a country. But
in the whole world, there's no country
that
has
I haven't researched
so,
that.
Bernard, let me provide some of the countries.
Yes.
Yes. England, Norway, China, United States of America, France, Sweden, Finland, and about 19 countries that I know of.
Mostly developed.
Yes.
Mostly developed countries.
But the issue now is, why do people call for vaccine injury compensation programs? Because it helped to maintain trust in public health administration. You understand? Because my mom here has good intention. From, as she said, I've met her on other platforms. And from the way she speaks, she has good intention. There's no way she would sit somewhere and try to harm any child in Ghana. She wouldn't do that. But Bernard, if you research about the Tuskegee experiment in the USA, which caused the former president of the US, Bill Clinton, to render apology from the White House to the black community in the US, where scientists used blacks in Alabama for 42 good years, injected them with syphilis, just to see how syphilis would behave in human beings untreated. For 46 good years, it took an investigative journalist who went underground to realize that the people in Alabama have been used as guinea pigs to test how syphilis behave untreated. And the president of the United States of America in 1997 realized that if he doesn't come out to apologize to the black community, it will be difficult for them to trust anything that's coming from the public health sector. Right. And he did that. And even after that, many of black people, if you ask them, they said after what happened in Tuskegee, they don't trust
themselves.
You understand? So, Bernard, let me educate people here. If we have vaccine compensation programs in place, do you know what will happen? One, any company that would think that, oh, this country is porous, as we are talking now, Ghana is porous. This country is porous, so I can tell that I'm bringing a malaria vaccine, but at the back of the backside of their knowledge, I'm testing another thing. Or I'm
saying,
if you're saying Ghana is porous,
Ghana is porous because if somebody wants to do what they did in Tuskegee, they can simply do it here because
there are different rankings for the quality of health care provision in various African countries. So if you say Ghana is porous, is it on just anecdotal evidence, or is there any ranking of porosity or laxity in health administration?
The laxity here is that once there's no anything that will make a vaccine company or any drug company think that if I take this thing there, the people are now educated. Whenever they take vaccine, they will take good care of themselves. They will monitor themselves, and if they see any reaction, they will either link it to the vaccine or the drug and go to the nearest hospital.
So you're saying there's not enough information. All right, guess what? I'm trying to.
There's something important here that I want to.
I'll give you a chance.
No, let me finish. I want to finish something here.
Yeah.
Because when that is done, the company will realize that if I deliberately or indeliberately send either contaminated drug into that country and somebody get any adverse... Yes, there's FDA, there's Standard Board and all of that.
Evans, hold on. You are using a lot of if. You have not provided evidence, or you haven't given... You are saying something happened in 1972 in the US. I do not doubt that. Now, to impute the sins of 72 onto 2019 is one issue. Number two, you are talking about what could happen. You are not telling us facts. You are saying that if a company decides on the basis of our porosity to do this, but we don't know if they've done that. You hear me? So what you're saying is you are being... No, I'm just trying to understand.
So let me give you an example.
Okay, I'll take a break. So we all relax. We'll take a short break. This is the point of view. You are trying to understand what is happening with the rolling out of the first major anti-malarial vaccine. And my guest in the studio, Evans Teria, from the Coalition for Ghana's Independence Now, one of the NGOs who are saying they are against the rollout of the vaccine without a compensation program for those who may be adversely affected. I also have Dr. Kezia Mam, who's in charge of the malaria control program. Please send us your comments and your views on this issue as well. Stay with us.
The conversations that help you shape your spiritual journey as a Christian. Find the answers you seek. Catch the 700 Club with Pat Robertson every Sunday morning at 8:30 a.m. on City TV. The policy makers, the top personalities, the people at the center of the news. They speak on Face to Face. One-of-a-kind access into the lives and the stories of our time.
So these are some of the things. If you want time, as I was boarding the plane,
it just
in the
came
queue,
to you.
Just straight from the launch to the queue, a song dropped. So
Face to Face with Godfred Akotobuafo every Tuesday at 9 p.m.
Welcome back to The Point of View. Tonight we're trying to understand the historicity of the rollout of the RTSS, which is the new vaccine that GSK, GlaxoSmithKline, is implementing in 3 countries, Malawi, Kenya, and Ghana. And my guests are Dr. Kezia Mam, who's the lady in charge of our malaria program, and Evans Tewia from the Coalition for Ghana's independence. Now, let me read a few of your quick comments. Good evening, Bernard, and to your panel and the entire Point of View. For me, it's a waste of resources to initiate the malaria vaccine. Is this anti-malaria vaccination important at the expense of educating and conscientiously advocating for prevention? Why always Africa? Boga Ali Hassim. Bernard, ask for me, if after the trials there's an anomaly, what is the remedy to these children and how have they dealt with such issues in the past with respect to damages? Alexander Tinkran from Medina. I think without clinical trials and piloting of vaccines, we wouldn't have a certified, efficient, and effective vaccine to treat diseases like polio and others. From Stephen in Kintampo. If Africa is the hub of malaria, why don't we focus on the root cause, but rather giving room for it to increasingly spread, then come out with a vaccine under the guise of intervention? There are a lot more comments. Bernard, in Agogo, there was no indemnity form or compensation for people used as trial under the GHS. Dr. Mam knows that all persons used for the vaccination who have severe adverts were not compensated but rather treated like normal patients. This is Dikadi from Spintex. There's a lot more. Let me see if I can get some of them through before we continue with the... Yeah. Apia says, Bernard, I think people are becoming alarmist on this vaccine trial. And it appears we have lost sight of the trajectory of drugs from the design till it gets to the shelves. Every drug has to go through trials. Today, we are having antidotes against diseases which in the past century killed millions of people before vaccines got invented. Do we know the cost of malaria to the health of the economy? Certainly, the naysayers are saying we do not need Ghana to be used as a trial nation. Then, by extension, we should also not expect the manufacturers of the drugs to sell them to Ghanaians when the drugs become successful after the trials. This is Apia. So, send your thoughts to us on the WhatsApp number on the screen. Doc, let me come back to you on a quick question. We are saying, okay, there appears to be no trials on other diseases like tuberculosis and neonatal conditions, which constitute a significant contribution to morbidity and mortality in Ghana. So people are asking, why malaria? I think you explained a bit of that. I want you to go back there because in this article put together by George Ajay and Abdul Sule, they say, if you can permit me to quote, although the number of trials of interventions against major communicable diseases evolved in response to either increased incidence or increased awareness of the disease, trials of interventions against major non-communicable diseases whose contribution to overall morbidity and mortality in Ghana is consistently increasing are few and virtually non-existent. So basically, just wanted a rubric on how a company chooses this one and not that one.
Okay, so Ben, I think I need to correct something. GSK is not implementing the pilot introduction of the malaria vaccine.
Okay.
Let's get that very clear.
All right.
It's been taken up by the Ghana Health Service and WHO. It was GSK that manufactured it.
Okay.
And currently they donated it to the World Health Organization and it's working with these 3 countries.
Okay.
2, it is not possible under any circumstance for any manufacturing country to bring any vaccine into this country to use. Not in Ghana. Not under the Food and Drugs Authority.
Okay.
It won't happen.
Okay.
The Food and Drug Authority is one of the centers of excellence in this in Africa.
Yeah.
It can't happen. So people should be assured that and in fact, Ghana Health Service can't allow that. So we need to know that. And now to your question.
Yes. How do they choose which one to introduce trial? Is it a pure economic decision?
No, it's an issue of development, I'm sure. But we have a vaccine against tuberculosis already.
Yeah.
Yes, so that's a BCG. It's an issue of science, development, the burden. Malaria is number 1. So it's something that we would have tried long time ago if the vaccine was available. And I think it's usually, from what I know, it stems from the burden, the need, scientists going to work, bringing up tools, and then eventually it's tried to be used. Because if you don't have a huge burden, then it's not something of interest. But for us, malaria is number one. So it's of interest to us. Basically, that's how. And this has been, in fact, it's even too late.
There have been a few write-ups about the drawbacks to this particular RTSS or Mosquirix. So, for example, we are told that the drawbacks include the following. Surviving the disease does not provide lasting immunity. People who suffer numerous bouts in childhood become able to tolerate new infections. But if they leave the area even for a few years, their immunity wanes and later an infection can kill them. The new vaccine has many weaknesses. It is inconvenient. That's number one. A child must receive 4 injections before age 2, sometimes at intervals that do not match the routine vaccine schedule for most other diseases. And then 3, which is the key one, it is only partly effective. Testing in more than 10,000 African children from 2009 to 2014 showed that even after 4 doses, the vaccine prevented only about 40% of detectable malaria cases. And then it goes on to talk about whether there was a perfect match or not. I'll come to that. What are your quick comments on this? And some of these, because of this, Doctors Without Borders chose not to take part in the initial rollout because they said that their resources will be better spent focused on other malaria treatment programs. Again, this is a fact. So my point is, comment on these drawbacks and why a credible organization like Doctors Without Borders would not endorse this process.
40% of 5.5 million, if you bring it to children under 5, which may be like 2.5 million cases in a year, is way significant for us not to use it. That 40% can be somebody's child. It can be my child. So for us, 40% is significant. And if you look at the control of malaria, each of the interventions add on for us to get the impact. There is no single intervention that is 100%. Otherwise, my job will be much easier. So 40% is something we can't let go. Most of these vaccines are not 100%, but look at the impact we are seeing with the vaccines. That's on a comment on the partly efficacious.
Yes.
That's why we say it is an additional tool. Don't forget all your tools and say, once I have the vaccine, I won't do anything else, because you may still be at risk. So it's an additional tool.
Some people say the schedule of the vaccination is a bit complex.
Yes, so what we try to do is to try and make sure it goes with the immunization schedule in country. So you go in at 6 months, and 6 months you have to go for other immunization. So that one is easier. 7 months you have to go back to where your child, so we'll get the children. 8 months you have to go back if you didn't come early to get your child with. 9 months you go in for measles, so that's okay. The difficult one is the one that you have to go back at 24 months. And that is why we are even doing this pilot implementation, because it's so important people get the 4th dose to get the impact that we saw in the trials. So the questions we are asking is, how will we be able to get people to go back for the 4th dose? You know, around 24 months, children have to go for vitamin A. But it's not, we don't have a high number of people going as we see them when they are under 1. So people like you should help us. I mean, these programs should help us talk about encouraging people to go back for the 4th dose so that we get the benefits that we saw in the trials. The first one has to do with the inconvenience, right?
Yes, so the inconvenience. Now, there's more, and permit me to just read more. So the medical journal study, looking at blood samples taken from 4,600 vaccinated children in the last clinical trial, found that the vaccine worked only about half the time when it was a good genetic match for the parasite a child had, and only a third of the time in bad matches. Then it says, more than 90% of the time, the matches were bad. And then it adds, malaria parasites are famous for evolving drug-resistant strains, and scientists have worried that changes could make them impervious to vaccines as well. So that the most prudent course would be to improve the matches so that the chances of reducing all the bad effects are heightened.
I am sure the scientists are still working. And if you look at malaria control, we've evolved. We've moved from the point where every fever was equal to malaria to the point where we have rapid diagnostic tests and people are checking and confirming on the shelf. This is the beginning. And for me, I don't think that we should sit down and let people die today because you want something better. You make use of the best available tool that you have, and you continue to work to improve on it. And that's where we are with the vaccine. I am hopeful, probably if I live to see in the next 30 or 40 years' time, this vaccine would have even improved.
Again, during the phase 3 trial of the RTS, there were many cases of meningitis, or there were more cases of meningitis in children who received the vaccine than in those who did not.
Yeah.
Although no causal link has been established.
Exactly.
Okay. But is that not an issue of concern?
It is. That is why this pilot implementation will bring us more information, because you see, we work with information, facts. The fact was that there were more in those who were vaccinated than those who were not. But we're not able to establish causality. And until we are able to establish causality, we'll have to gather more information.
But the problem is that causality may be established 30 years later when the damage is done. That's what people are afraid. And they've given instances of other vaccines like the H1N1 and some of the vaccines used and the adverse effects on even the health workers who used it. So some people feel that if we can't establish, you're saying there's a correlation but no causality, so no problem.
Not correlation. They saw...
So that's a correlation, but not the causation.
But Bernard, if we did... I'm sure if you knew this paracetamol, you wouldn't even take paracetamol. It's the collection of information each time that informs us. So today we have this information. If we don't continue to save lives with what we have today, and then as we save the life, we get more information, we wouldn't be anywhere. We wouldn't get anywhere. The same happened, in fact, when paracetamol came into being some years ago. We didn't have the information we had on paracetamol as we have today. That is why we do what we call post-marketing surveillance. Once drugs, vaccines. One thing you have to know is that we, in terms of looking and ensuring the safety of vaccines and drugs, there are standard protocols for both drugs, for vaccines, and there is no way as a country, as Ghana Health Service, we are going to sit down and bring in things that we think will harm people.
Evans, what are your other concerns? In your statement, you raised quite a number of issues. So you
and you are not allowing me to talk.
Yes, I've come back to you. No worry, I know what I'm doing. So let's come back to you. What other concerns do you have?
So first, I want to put out some questions. Then I need some answer. I'm saying that if vaccine injuries are not issues that we should look at, that we say we should put vaccine injury under the carpet and look at so-called saving life. Because I think vaccine injury programs are also going to help improve saving life. If it's not important, I'm not sure our framers of the law will indemnify it. We even think of it and then indemnify it in the first place. 2, in 2009, when GSK brought the swine flu vaccine in Ghana, the same vaccine was used in the UK. People got adverse effects. Some people went to court and they got compensated. 2 people among the many, but 2 people who went to court and won. They got compensated with $63 million in the UK.
Okay.
And I can give you the lawyer who stood in for these people. In 2009, the same vaccine was used in Ghana. We heard of people who were fainting and all of that. But because in Ghana, that perception has been created that vaccines are that cool, pure, it has no effect. When people even got it, they didn't even think of seeking any redress. That was 2009. We didn't even have the current Public Health Act. The current one was passed in 2012. And it is in it that you're saying that anybody who goes through trials and get adverse effects during or after has no redress. You understand? And what we are saying is that you can say that, when 10 people are vaccinated or immunized, only one can have adverse effects. And therefore, looking at the percentage of those who didn't get injured, it is okay. But it's only civil justice that person who got injured during that vaccination or immunization sacrificed his life for the 9 people.
But are the injuries have deaths? I'm not saying people should die first. So she's saying that, and we are told that, so you're saving people, 4 out of 10, for example, are being saved. And if you multiply that by the millions who have the disease, you are saving thousands of lives.
Exactly.
Now, these injuries you are discussing, are they fatal?
They are seriously fatal in most cases. When yes,
That is
Really?
So
yes,
Can
when
you provide us
As
with
in,
the
when you say
facts?
fatal, I mean it results in
In
death.
most cases,
some like in UK,
Yeah.
the same vaccine that was used in Ghana, that people didn't check themselves in 2009.
Was it
the
a
people who were awarded the
trial?
$63 million got brain damage.
was it a phase 1 trial, phase 2 trial,
The
phase 3
vaccine
trial?
that was used in the swine flu vaccination, because it was a
phase
rush.
1, 2,
It was a
3?
rush. What we are saying is that we don't care the state of or the phase of the vaccine. Vaccine can injure you. Other than that, the lawmakers wouldn't mention
But
the injury.
my question to you is, I don't doubt the injury, but I'm just saying, juxtapose the lives saved versus injuries. Now, you haven't proved that the injury resulted in death. And I'm not saying people should die.
So,
but if you are saving 2.5 million people.
What is life when a potent, strong-bodied man has got brain damage? For example, autism.
Can you provide a bit
Forget
more
about the
evidence
person
on-
who's bearing the autism, the parent who take care of them. If you don't get a rich parent, how easy is that?
So
you understand? So we shouldn't only look at death.
No, but
You
the
understand?
other question is that is there any foolproof method of health intervention?
Health intervention.
So people will ask me to ask you, so somebody brings resources to put together a drug or a vaccine and takes like 30 years to go through the process of testing it to make sure it works and then decides to roll it out on a massive scale for people to be saved.
Okay.
And you're saying that there's a likelihood that some people would get adverse health effects.
Yes.
Good. And I'm saying, what is your alternative health intervention which is completely adverse free?
Okay, so this is where I think many people have not got what we are saying. What we are saying is that we are not saying people shouldn't do it. But for all these years, go for the vaccinations.
Oh, thank
So
you.
they should go for it.
Not now.
When?
Until we amend our law. I think in Ghana, when something is important, we lock up parliamentarians under the
So I think
certificate of
I'm getting
agency.
something from you. You're saying that you are not against the usage or the trial.
Yes.
You are against it without.
At this current,
So what do you want the law to say? Or what do you just tell us what do you want the law to include?
we want the law to be amended for the state to be responsible, or the state corner the vaccine companies to be responsible for any adverse effects. Because I've not got time to explain why.
So I think that point is still strong. It hasn't been debunked.
Yes.
That there has to be some way of the state bearing the cost of any adverse effect of the trial.
Exactly.
Which I would insist Dr. Casey addresses. I wanted to show you on the screen, if possible, the timeline we've gone through in this particular process. So, Sam, if it's there, please let's see it. And which regions that the rollout is being done. And then we can get Doctor to comment briefly on it before I take my break, if we have that. So we've gotten a document that shows us since 1994, I believe it is. Yes, this is not very clear, but just I'll walk you through it. So it's the RTS journey, 1984 to 97, early development of the drug. 2004, efficacy first shown in young children. 2009 to 2014, efficacy proven through large-scale clinical trials. 2015 was a significant date. European Medicines Agency issues positive opinion of the vaccine. By 2016, WHO had recommended a phased introduction in selected areas. By 2017, Ghana, Kenya, and Malawi had announced that they will implement. And then Ghana's FDA in 2018 approved the vaccine. And then in 2019, it started a rollout. If you look at the map in the top right corner, any quick comment, Doc, on why these regions were chosen? So Bono Ahafo at the time, Volta, and then here Central and Upper East.
Yes, so the main routine introduction is in Bronga Ahafo, Central and Volta region. And the basis for their selection was, one, you should have malaria parasite prevalence in children under 5 of above 20%.
Okay.
You should have a very robust immunization program. You should have a good malaria control intervention levels in the region, because, like I said, this is an additional tool. And also, we couldn't do it in the very northern regions because we had seasonal malaria chemoprevention and additional indoor residual spraying, and we didn't want it to confound our comparisons, to learn the lessons from it. So we came to the regions, these regions, based on some of these concerns.
We'll take a short break. When we come back, there's more. We are still trying to understand the trajectory of the new malaria vaccine and what it will do. Stay with us.
Let's take you on a journey of discovery. The incredible sights, artifacts, music, and adventure. It is what makes life worth living. Our history, the arts, and soul. Art and Soul with Melissa Awad. Saturdays at 8:30 a.m. Only on City TV.
Art and soul, art, soul, art and soul, art, yeah, soul, art and soul, art, soul, art and soul. This is the voice of inspiration.
It's inspiration. It's the word. The teachings.
When is your time? When is your season? When is your turn? No amount of lies, no amount of liars, political liars, financial liars, family liars, hatred or spiritual liars, no amount of it can stop you.
Tune in to Voice of Inspiration with Archbishop Nicholas Duncan Williams every Sunday at 6:30 p.m. on City TV.
Let these words
Welcome back. This is still the point of view, and we are discussing the safety of the rollout of the new malaria vaccine. Ghana, Malawi, Kenya, 3 African countries piloting this process, which we understand has taken 30 years, and this is a Ghana Health Service rollout. My guest, Dr. Kezia Malm, who is in charge of Ghana's malaria control program. Evans Teria is from a CSO, who are saying until there's a compensation for injury, we should not accept the vaccine. Let me read more comments, this time on Facebook. Kwekwa Jekum says, vaccines do not get rid of mosquitoes, cleanliness does. The solution requires cleanliness, not vaccines. David Bo says, let's talk about the cause of malaria in the first place and pilot a prevention program. Nibote says, Africans are always accepting everything from the West, knowing very well that we don't have the technology to test them for side effects. When did Africa's problem become the world's problem? Ishmael Hoke. So that was skepticism out there. Ghana is porous because even our scientists here can't do their independent research on what's coming. They just accept everything. Another one said, Bernard, at least the guinea pigs deserve prior information on the pilot vaccine to make informed choices to take or not to take. Doc, there's a very strong view that we did not do a proper communication and public education on this rollout. Indeed, some people have shown me a document that was put together but never implemented. So some of the comments are saying, number one, we don't have independent research. Yes, this was initially started by a private company. Yes, our FDA checked and said they agreed, but people feel that we are not really in control in terms of, we didn't initiate the process and we are essentially accepting what larger global organizations say to us. That's number one. Number two, we haven't spent enough time educating and informing people about this. And even me in the media, I'm not sure how many programs they've organized for us to be told about this. And is it that I'm mistaken, or because of all the speculation out there, you decided to be quiet on this?
Okay, so let me start with the issue about the researchers being independent. Please, we do have very knowledgeable researchers in the country who are independent, who had tried this. And you see, in clinical trials, we have something we call data safety monitoring boards, who have access to the data as the researcher is doing it, or with the researcher not even knowing the results. So if things are going in the wrong direction, the trials are stopped. And that was what was done with the trials. We have moved on. So we have African researchers, not European researchers, for somebody to think that this is being white doing something to the blacks. No, these are blacks researching on diseases that affect
Are you
blacks.
talking in this specific case?
Yes, in this. It was tried in Kintampo and Agogo by Ghanaian researchers who have done work in so many
No, but they're
other...
not developing. They didn't develop it. They just
Yes, it
tried
wasn't-
somebody's medicine. They
yes,
didn't develop
wasn't
it themselves.
developed.
Yes.
That's true. And it's
Public education, even media education.
we did a
Really?
lot, but now probably we could have done better. I don't take that. We did quite a lot. But if you go to the regions,
Did you have a
where-
communication program?
We did.
Really?
If you
What
go
did that
to the-
involve?
And it involved training journalists. I thought you were trained.
No, the first time I'm not part. Maybe I'm not that important, but I'm sure other journalists were
I thought you were trained when we were doing the trials.
trained.
Yes.
It was like
I was
a half day program.
Yes, so
For this big program.
that's what we did for a number of journalists, and we thought that
Okay.
the journalists have understood. So
Okay.
we could have done better, like you're saying.
I see.
The regions where we are actually having these pilot implementation are very well educated.
So if I go to OT region now,
if you go to the
and I
ground,
meet
people-
a random mother and I ask her about,
you could try it, and then
they would say they are aware of this.
it will help me to
So
know
you did
whether
local
yeah, we
language
did-
engagement in communities.
Yes, that is where our focus has been, the local level engagement of communities. More so because it's not nationwide. So local level engagement. But you see, we did expect some of these non-vaccination groups, and it's not just in Ghana, it's everywhere. If you go to US right now, they are having measles outbreak because people were told not to. You talked about mothers who were skeptical. So I get worried when people come up and say, don't go. The consequence of not vaccinating your child, please, I'll tell the mothers in the world, it's dire. Vaccines save lives. It saved us from measles, polio. We now have a chance with malaria,
Some people
which
fear
is
that
our number one disease.
one unintended consequence of the vaccine for malaria, with all its good intentions,
Yes.
could be now that you vaccinate the children, people will relax. The mothers will relax in doing the other things, the mosquito-treated nets, all the things you need to do to prevent malaria, which have also been proven to be effective. They'll relax.
That's why we are still talking. In fact, I want to tell them that don't stop the other ones. And somebody mentioned tackling the vector. We are not giving up on that. If we clear the breeding sites to make sure that we have less and less mosquitoes which can transmit malaria coming up, it will reduce the malaria burden. But malaria control is a multi-pronged approach. We don't have one bullet. So we are using all the arsenals that we have. And we've used these arsenals till now. Now we have an addition. It's all in an attempt to reduce this disease that is causing us a lot
Evans,
of
I'll give you the final word. You've said already that you want a program. Have you been to Parliament already? What is your CSO's agenda, except the radio things?
we try to issue some document to the Parliamentary Select Committee on Health to see if they will heed to our call for us to change. Because, and actually, we've been successful in 2015 to stop the Ebola vaccine trial. We thought the state was serious and we're going to take up from there. But we've been here this evening on TV tells us that the state doesn't care. So we are.
They haven't acted yet.
Yeah.
So you have a lot more work to do.
Yeah, so even right after this, it's not only about the malaria vaccine, but we're going to start an extensive campaign to people to always monitor themselves right after taking any form of vaccination.
And the report.
You understand?
Which is very good.
That is
Which
one.
is good.
That is one. Then our main concern, nobody should go until there's a law
All right.
amendment in place.
I can't endorse that.
Because
More
Bernard,
people would
I'm giving
Evans.
City News and
And-
City TV an assignment. Start going to homes and interview people.
Okay.
Who will tell you they are sitting in wheelchairs and other stuff because of immunization.
Thank you very much. Evans, we have run out of time. My guests have been Evans Teria from the Coalition for Ghana's Independence Now, Dr. Kezia Mam from the Malaria Control Program. Let me end with two final comments. There are loads of anti-malaria herbal medicines in Ghana, more effective than this vaccine. No need to reinvent the wheel with the questionable vaccine you are obeying. And then somebody says, vaccine is money. There's a race to find which company gets them first. GSK is the largest pharma company in the world. I smell a rat. We can't stop all your skepticism, but we will also track and monitor what happens. Thank you for being with us. My name is Bernard Avle. Stay with City TV. Goodbye.
Point of View is brought to you in association with Stanbic Bank, moving forward.